Okay, hello everyone. Hopefully everybody can hear me. My name is Erin Schwartz, Director of Global Advocacy and Strategic Partnerships with the Max Foundation. It's my pleasure to welcome advocate friends from around the world to this presentation on the use and management of Iclusig. Today's presentation is in the form of a webinar, and participants include members of the Max Foundation's global team who are here in person at the Oregon Health and Science University in Portland, Max team members in targeted countries joining through the web, as well as a handful of global advocates joining both on the web and in person. I want to thank everyone for accommodating the timing of this call, which crosses many different time zones. The purpose of this webinar is to create a space where we can come together as advocates to learn more about the latest TKI approved in the U.S. called Iclusig, which is also known as ponatinib and made by Ariad Pharmaceuticals. We are fortunate to be in the presence today of Dr. Mauro, Associate Professor with the Knight Cancer Institute here at OHSU, a well-known key opinion leader within the CML community. Dr. Mauro has firsthand experience caring for patients using ponatinib through his role as an investigator during the ponatinib clinical trials. We thank you, Dr. Mauro, in advance for sharing your insights with all of us. Before we get started, given that this is a mixed webinar and in-person platform, I wanted to share just a few announcements. It's important for everyone to know that the audio portion of this event is being recorded and may be shared publicly, such as on the internet and among advocates. For the integrity of the recording, we ask listeners to mute their lines during the presentation. We also ask that listeners save questions until the end of Dr. Mauro's presentation, which is approximately 30 minutes. There will be ample time for questions and answers. Anyone speaking will be asked to, if you're at home, I guess, talk directly into your microphone, and even here, speaking loudly and slowly to give our diverse and faraway audience the benefit of hearing and understanding us. If you're having trouble hearing the audio or seeing the slides at any time, please use the chat function to alert my colleague Erin Lindsay, who will be handling the technical aspects of the program. Thank you so much. Without further ado, I will turn the platform over to Dr. Mauro to begin his presentation.
Well, thanks, Erin. Thanks everyone who's in other places in the world. My life over the last 13 years has been very much fighting time zones, so I realize the challenge of that, and I appreciate all of my colleagues and friends in the advocacy and the clinical program here at OHSU who joined me today. It's a real treat for me to be able to talk to you firsthand about ponatinib and share some thoughts and perhaps level the playing field or deliver some more information that people might feel that's quite important to understand in places where ponatinib is not available, where it's available, and how we might use it, and particularly looking at the side effect profile, as we have a number of therapies in CML, side effect profile becomes an increasingly important question. So first we'll look at ponatinib from a scientific and a basic level, mechanism of action, preclinical data. So ponatinib, much like imatinib, was a rationally designed inhibitor of BCR-ABL. Imatinib was designed based on a previous known entity of tyrosine or small molecules that would inhibit BCR-ABL. And imatinib was chosen from a panel of medications with potential properties. With imatinib, we had a very good structure to start with. And as you know, or may know, many drugs have come since then built on the same concept. Ponatinib being the last of TKIs developed and approved, was able to take advantage of structural chemistry and the knowledge we had of resistance and much more information about the binding of ABL kinase inhibitors to the active and inactive conformation and the binding domain. So on this slide, you can see on the right, let's just look at that and see that because of the shape of the molecule, because of the bonds between the molecule itself and the ABL kinase, ponatinib was particularly chosen structurally because it was able to still bind BCR-ABL in the presence of a very significant change in the structure of BCR-ABL, which is a isoleucine threonine substitution at the 315 position. That's amino acid number 315 within the B-cerebral kinase. It wasn't chosen strictly for that reason, but that was indeed a task that needed to be overcome. We needed a compound that could work in the presence of a B-cerebral that was changed in that way. So it was unique in the way it bound B-cerebral. It binds able in an inactive or closed conformation, which may be an advantage. That's been a debate, and the different available inhibitors bind inactive in the inactive and active conformations depending on the drug. Because it's a small molecule kinase inhibitor, ponatinib's got other targets. It's an inhibitor of the vascular endothelial growth factor receptor, the fibroblast growth factor receptor, and the platelet-derived growth factor receptor, as well as c-KIT and SARC to varying degrees. Relevant kinases that may be active in leukemia could include any of these. And in fact, I would throw open the notion that as we look and understand these drugs better with more use, we may see that some of these are relevant targets. It's also potent against the FLT3 kinase, which is a target that's been well known in AML, and there are therapies developed specifically for FLT3. And ponatinib itself has been tested in a limited fashion for AML bearing a FLT3 mutation, and I think we still may need more work in that area, but it may have other disease roles. It is clinically active in CML. We'll show you some summary data. We'll go over some summary data. And again, as I just mentioned, it's been tested in AML. It's a once-a-day oral drug. We were honored to be part of a phase 1 trial here, as well as the phase 2, and we'll be part of the phase 3 trial. And a long and carefully run phase 1 trial established the maximum tolerated dose and the safety. Patients started at very low doses, much like imatinib phase 1 trial did, and the range was between 4 and 60 milligrams daily. Initially, the trial included patients with refractory hematologic malignancies, but really quickly with time focused on patients with pH-positive leukemia, and the phase 2 trial included all phases of pH-positive leukemia, meaning chronic, advanced phases both. So the selectivity profile is something we look at with all the kinases to understand, because the able kinases are similar in many ways. So the enzymes on this list, there may be infidelity, as we might say, between a molecule that might inhibit one and its ability to inhibit another. So this list shows you the lower the better with regards to IC50. That refers to the concentration required to inhibit a kinase inactivated with a drug. And you can see the relative amount of drug you need to inhibit different forms of the able kinase. And some of those are the mutations that we may commonly see in clinical practice. And in particular, what's unique about this list compared to other lists you might have seen generated is that the T315I able kinase doesn't need much of this chemical to inhibit it, whereas if you looked at the same list with another kinase, you'd need an impossible amount of a compound, or an impractical amount of a compound potentially to inhibit a T315I altered able kinase. On the bottom of the list, you see other kinases, which again in the middle are some that are known targets for ponatinib. They may have something to do with efficacy. They may also have something to do with toxicity, so we need to look at that question carefully. And then on the bottom, some that are not affected, including some that have been studied in CML targeted therapy like the Aurora kinase. Preclinically, and these are basic science studies which supported the development of ponatinib in the clinic. This is a comparison in animals with B-cerebral-driven tumors in whom you give increasing amounts of compounds. And this is in a native or wild-type B-cerebral model. And you can see, for example, on the right, with vehicle, which is no drug, you see a tumor growth that grows very quickly and kills animals rapidly, so the tumor volume expands rapidly. And with dasatinib in a B-cerebral tumor model, once you get to a relevant concentration, for example, in yellow, you'll see that the tumor really slows down dramatically. And then at probably relevant concentrations, it kills the tumor shrinks. And then with ponatinib on the left, again, based on the principles we just talked about, the drug, you need less of it, and it's broadly applicable to wild-type and resistant B-cerebral. You see elimination of the tumor at lower concentrations. Speaking to the potency and the use of a drug and sequentially in a B-cerebral-driven tumor. In other studies, specifically looking at the T315I and focusing on the ability of this specific compound to, on the left, extend the survival of an animal that has been rendered ill with a B-cerebral-driven tumor, you can see that the colors might be a bit hard to note, but with dosing and then interruption of dosing, you see that at increasing concentrations of the drug, the animals would survive much longer, speaking to disease response. And then on the right, just reduction in tumor volume at different concentrations. And this started to give us an idea about what dose would be relevant. And you can see that at 30 and 50 milligrams, the two curves on the bottom, in black and red, that these are 30 milligrams per kilogram. These are not milligrams per day in a patient. So please don't equate that. I have other data that will tell us about that. But this is giving us the idea of how to convert to a relevant dose in humans. Not to belabor in vitro data, but this looks at the difference between, in blast crisis, a T315I-driven and a wild-type BCR-ABL in the curve on the left, how ponatinib can actually work quite well against both, sort of equally, which is quite remarkable. And on the right, how the principle of how these drugs work, which is stopping phosphorylation and activation of BCR-ABL, that stops phosphorylation of crackle, one step down from BCR-ABL, and if it's been inactivated, we see that BCR-ABL has been shut down, and that's the case with all of the drugs, and particularly with ponatinib in the setting of a T315I. All right, so now let's start to talk clinically. In the phase 1 study, which is presented and been published several times, this is a snapshot that has been included, I believe, in the New England Journal paper that we wrote. The responses for patients in chronic phase are shown, and note that the numbers are small, but this was very promising and well publicized data. That in chronic phase overall, the majority of patients were put back in and sustained blood remission, 98%. The cytogenetic remissions happen in a majority of patients, and including with time complete remissions and molecular remissions as well. And this study has a follow-up of a few years now, but these responses were generally very early. In the middle, you see a very small number of patients with the T315I mutation, and we'll get into the details of why those patients respond perhaps better in a bit. And their response was even better, with really all patients with hematologic response and a higher fraction of major and complete cytogenetic remission as well as molecular remission. And then the non-T315I in comparison. So this is a snapshot of chronic phase from the phase 1. It's important to note when you look at phase 1 data that many of these patients didn't have a relevant dose of ponatinib during the early months and maybe even an extended period of time of treatment. So as well, speaks a little bit about the nature of patients in chronic phase who have resistant disease, that we're able to treat them over a period of time and see response. So same study, but now looking at advanced phase, accelerated phase and blast crisis, you can see that the activity is much more limited, that in overall activity is about a third of patients will have hematologic and cytogenetic response. Complete cytogenetic remissions are more rare, and molecular responses may be limited to patients who have select forms of resistance. Now, I would say that advanced phases of CML, we're starting to learn a lot more about, and I only have a short time today. I mean, to give you a bit of an idea about that, what may be going on, for example, in an advanced phase patient is not just a single point mutation in a clone, and that's the population you have to treat. You may have compound mutations, multiple mutations within a clone, or very unstable disease where mutations can occur very easily. And while ponatinib may be active, it may not be active for the majority of patients, nor may it be active for the longer term. So we see it as a drug that's got clear activity in a highly resistant population, and maybe a good bridge to a second therapy, for example, to stem cell transplant. So the phase 2 study, the endpoints are shown here, and the endpoints are shown on top. So for chronic phase patients, again, the goal was at least a major cytogenetic remission, in accelerated and blast phase hematologic remission, and the numbers are not very different. In chronic phase, we see more than half of patients with cytogenetic responses, 50 to 70%. In accelerated phase as well, there's a good degree of activity. Now, remember, those are hematologic responses. And again, about a third of patients with advanced forms of Th-positive leukemia with response, major hematologic response being a very good sign. It may not be a long-lasting remission, although it certainly can be in some. So I think the phase 2 study needs more time to follow up and more careful follow-up. And what we can see is confirmation of what we saw in phase 1 in a much larger patient population, and of course, better safety data. If you look at chronic phase patients, digging a little deeper, and again, this is 267 patients, cytogenetic responses are in about 2/3 overall, with a little over half having a major response and nearly half a complete cytogenetic remission. Molecular responses are fairly prompt, with the thought being if you're sensitive and you go on to cytogenetic remission, particularly complete, you're likely to continue on to molecular remission. And as well, incorporating newer expectations of response. I wouldn't say that we expect the same of a newly diagnosed patient and a refractory or a resistant patient at 3 months, but a sense for how quickly the transcript level might fall with ponatinib compared to other drugs. So 60% of patients having a rapid transcript reduction. And the time to response is also fairly rapid. I'm particularly impressed by the rapidity of molecular remissions in only 5 months. Of patients who respond to ponatinib, I think I've been impressed clinically with the patients I've seen is that the degree of patients who lose response having gotten back into hematologic and cytogenetic remission is very small. And if you look at the overall data from the phase 2 study, the numbers would confirm that. And the longer-term survival curves hopefully will look very good. And the duration of response in this figure here is very encouraging. Here's some early survival data, progression-free survival on the left and overall survival on the right. So progression-free survival for a patient population, many of whom have had 2, 3, or 4 kinase inhibitors. I'm particularly encouraged by that. I want to see the further follow-up to confirm that we don't see continued deterioration, but those curves are very impressive. And on the right, overall survival. And thank goodness we still have yet other therapies in CML. Patients are able to move on to transplant or other options. So even in the face of sometimes progression, we're able to still keep patients alive and put them back in remission other ways. So I think the future is quite bright here. One of the specific questions to address was ponatinib activity in certain mutations. And I spelled mutations wrong, which I think after 13 years I probably could get that one right. So please note that on the after talk assessment that I need to back to the drawing board. So CML mutations that's what happens when you do it at 3 a.m. You spell mutations wrong. If we look at CML, the story is fairly consistent, and this is an old figure from Timothy Hughes, but it really is still true that we see mutations clustering in certain regions, in the activation loop, the phosphorylation loop, and the binding domain. So these numbers still hold true. If you look at mutations by disease phase, and this is also from the Australian group, this is from Sue Branford, you see that, for example, highly resistant mutations like the T315I all the way to the left are seen in more numbers of patients, particularly with more advanced forms of disease. And then certain mutations are more common in certain phases. It's unfortunate, and it's probably the reason why we see poorer response in advanced forms of Ph-positive leukemia is that we see more of the more challenging mutations based on the drugs we have, and probably the ability to develop new mutations. So we have a fairly good knowledge about how mutations behave. I put this figure in just to remind everyone that when we talk about mutations in Ph-positive leukemias, take a hypothetical group of patients, 100 patients, and treat them with a drug. In this case, imatinib. You may come out with a 30% fraction of people who are resistant to therapy. Of those, pretty consistently, half of them will have a mutation, and the other half won't. If you take that fraction of patients and then do careful analysis and say, in how many of them can you choose a drug or understand how to treat them based on their mutation profile, it turns out to be a very small number. So what we need to do is understand that of the half of patients with resistance, what mechanisms of resistance really are driving it, and perhaps understand a little better about how mutations behave and how they cause resistance. A question about when to perform mutations. These are from the Gemema group, presented by Simona Savarini, and I think are very practical that patients with advanced forms of disease are the only ones who really need mutation testing at diagnosis. For imatinib patients who have failure of treatment, the treatment fails them either by ELN or NCCN guidelines or any other practical guidelines, the patients lose molecular remission, and the patients who have suboptimal response as well, with that being a little lower yield but still important. For patients on subsequent lines of therapy, I think if they lose a previously achieved response, that's quite important in any setting. And really, actually, to track them until they come into a molecular remission would probably be even safer. This is just a setup for the next slide with regards to how ponatinib particularly performs. If you take a CML cell line and treat it a certain way, essentially render it more likely to create mutations, you have a very good engine to test how a drug works and how well it's able to suppress mutations. And this was the preclinical data from ponatinib. What we had seen previously is that with other drugs, if we used increasing concentrations, we could suppress most of the mutations that would develop in this model, which is essentially a cell line that is destined to develop mutations if you let it grow. But with ponatinib, at a concentration that was clinically achievable, we didn't see any mutations. So this was really one of the strongest platforms for developing this for resistant disease, is that in the laboratory, it looked to be a drug that could potentially suppress mutations of any kind. And this may be, at least in some part, one of the platforms by which we might consider it in the frontline setting, because if we could subvert resistance entirely and understand what the risk of that might be versus, but hopefully observe this benefit, that's an important question. If you wanted to ask a specific question about what mutations were treated with ponatinib, this tells you on the left the cytogenetic response for patients with and without mutations. There are some differences. Interestingly, patients without mutations sometimes do somewhat poorer, although not statistically significantly different. And the T315I in this study also performed very well. What you can see is that in yellow are patients responding to ponatinib, and blue is the number of patients with mutations. There are some types of mutations with lower likelihoods of response, but all types of mutations appear to respond to ponatinib, at least in a majority in most cases, or at least a significant fraction of patients. So there weren't any of the gaps, if you will, that a certain mutation was foiled by the drug. Probably another important question was how many medications have patients been exposed to. So this is the response by number of prior approved therapies. Major and complete remissions as well as molecular response. There's a fairly consistent pattern that the more kinase inhibitors the patient had been exposed to, the lower likelihood they had of response. Now, you have to interpret this data carefully and know that if a patient had one TKI, these were patients who had identified as a T315I mutation generally in this study. So yes, they did perform well, and I'll share with you an analysis that we did that might change the way you view why this group looks so good. And it's here now. So we did a multivariate analysis of the patients in the PACE trial, looking at their response and their profile, their risk factors, their age, their prior drug exposure, their prior response, to see if there were predictors of response that may be independent of the T315I mutation. And if you look at these figures, what we learned is that the T315I patients were younger in age, which is in the lower left. Now there's obviously an overlap, but the median is lower. And in the middle center, you see that they had received a higher dose intensity of therapy. Again, the medians are overlapping, but the range overlaps, but the median is higher. And they also had shorter disease duration and fewer lines of therapy. And these were all predictors of response. And when we looked at whether they had the T315I mutation or not, the probability of response was equal. Now, this is analysis of this data set. If you take it at face value, it might tell you that it wasn't necessarily that having a T315I mutation was the reason why this group did so well. It was because they were actually treated earlier, and they were younger patients, and they had less prior therapy. So, again, we're trying to understand best where to use the drug and whom it's best for. And I think this may dismiss what is the notion that this is the drug strictly for patients with a T315I mutation. I would definitely disagree with that, and that it's useful in many different patient types, and we may really benefit from using it earlier rather than saving it for later. I'm sorry, I didn't describe it. This was major cytogenetic response likelihood in chronic phase, and this is hematologic response in advanced phase. So even in advanced phase, having the mutation or not wasn't what predicted poor response, and it was really lines of therapy, age, and dose intensity. So let's turn to probably what was one of the main questions that have been generated lately about ponatinib toxicity. Of course, when a new drug is approved, it faces a bit of an uphill battle to prove itself, its worth, its benefit, and of course, its toxicity. Ponatinib being the 5th TKI approved in CML, the bar was very high, the knowledge very deep with regards to toxicity. There's a lot of preordained toxicities that were known and examined. I think the most important place is to look first at the clinical trial data. And this is the most recent presentation from ASH 2012 of the phase 2 trial for what are called treatment emergent adverse events. So adverse events occurring on treatment that were assessed by the investigator to be related to therapy. And you can see the numbers. And in many CML presentations, people like me have stood up or stood in rooms and said that the likelihood of grade 3/4 toxicities is very low, and that's true. I think if you look down the column of this grade 3/4 in the chronic phase in the total population, the things that jump out are abdominal pain, lipase increase, and pancreatitis, as well as hypertension. And we'll talk about that in a bit. And that's an expected toxicity of TKIs as a class. We know nilotinib causes lipase elevation, pancreatitis, and ponatinib clearly does as well. Abdominal pain is generally probably linked to the pancreas adverse events. But it's important to look at the whole table. I think on the bottom you see the myelosuppression likelihoods, and in a heavily pretreated patient population, I would comment that I think myelosuppression is surprisingly low. Thrombocytopenia is not trivial. It's about a third of patients have a grade 3/4 thrombocytopenia, but neutropenia is fairly modest, and anemia as well. These really compare the neutropenia and anemia to frontline treatment degrees of myelosuppression. So that may speak to the specificity and the potency of the drug against the leukemic clone rather than hindering normal hematopoietic regrowth. And then, again, things that might pop out are the hypertension, which we see some grade 3/4 events, and then, of course, the numbers of patients who have all grades of other side effects. And these are the things we might see clinically in practice are rash, which is a broad category, as you can see, headache, other dermatologic and constitutional symptoms, as well as some GI side effects. Probably a little bit more scrutiny could be taken on this slide, which would be treatment emergent serious adverse events. So these are the frequency of serious adverse events, any that had more than 6 patients. Not surprisingly, pancreatitis, abdominal pain, and lipase increase are listed with regard to GI. There is a box warning for vascular disease, so it's important to note in the total population in the chronic phase how many patients during study had myocardial infarction, heart failure, atrial fibrillation, and hypertension. And of course, these are serious adverse events generally requiring emergent treatment, hospitalization. So different than the list we saw just a minute ago. The next grouping is infection and other syndromes, so pneumonia, fever, and septicemia, fairly low numbers. And then complex hematologic toxicity that would be, deemed needing emergent treatment, transfusion, hospitalization, et cetera, fairly low. So probably speaking to the fact that myelosuppression is rather mild, actually. Now, there's a bullet point to mention that the arterial stenosis or any arterial event was noted in patients with cardiovascular risk factors. That's not saying that patients who had, none of the patients who had events did not have cardiovascular risk factors, but it's clear that in this population of patients, we are going to see a fairly robust profile of cardiovascular risk that is going to be heterogeneous, and its management isn't warranted by the trial. It's simply managed by best practice, as we would hope. So the trial obviously matured. The data was presented, and then the FDA has a chance to review the data, and a label is generated. And that's a discussion that, as investigators, as clinicians, as patients, as advocates, we're not privy to that discussion. And I think here's where we have to be particularly careful and look at the clinical trial data and look at the label and understand how to digest the data and interpret it. So we see the indication, which is it's a broad indication. It's for patients with all phases of Ph-positive leukemia, and that leukemia is resistant or intolerant to a prior tyrosine kinase inhibitor. So inhibitor therapy. So it's not limited to after a certain drug or after multiple drugs. It's a very open label. That being said, again, not to cite what discussions probably really are only behind closed doors and not for public consumption, but for a broad label, side effect reporting and knowledge for physicians wanting to prescribe it is going to be necessarily more broad. So the next thing in the label we'll see is the warning, the black box warning. Cardiovascular risk, obviously in a patient population like that with CML, is probably one of the greatest threats to patients. It's something we pay the most attention to, and there's a little bit of history in CML. Imantinib faced the question of cardiac risk with cardiac failure for approximately 7 or 8 years ago. That has generally settled down to the point of not being clearly felt to be above the background incidence, although we still see patients with cardiac adverse events on imantinib in whom we potentially ascribe it to the drug, even stop therapy and switch to other agents. Nilotinib has been noted to cause vascular disease, and I'll show you that data in a bit. Dasatinib causes arterial hypertension. So there clearly are vascular events that are occurring in all the TKIs, and I think one of the hardest things to understand is in a trial, can you ascribe an event like this to the drug, to the patient, and their independent risk, and it's not associated with the compound, or is it something in the middle? What we have to see is just the rate and decide for ourselves. So in the clinical trials, there's a report of 8% of patients having arterial thrombosis, and that would include patients with cardiac or coronary events, central nervous system events, peripheral arterial events, and of course, practically speaking, if you see that and there's a suspicion of drug effect, you need to stop therapy and consider discontinuation. The next black box warning is hepatotoxicity. All of the kinase inhibitors are metabolized by the liver. Patients with pH-positive malignancies often have complex medical regimens or complex past medical histories, and we have to bear that in mind. There were a very small number of cases of severe liver toxicity, and this is not new either. For example, the label of imantinib cited a single case of a patient who had excess acetaminophen use and hepatic failure on that basis. I think the 3 cases that are actually highlighted in the label were concerning, and the FDA viewed it as being necessary to be put in a black box warning. But I think more importantly, if we look at the clinical trial data, the incidence of hepatic adverse events, meaning transaminase elevations, isn't much different than the other TKIs. This just goes into more detail with regards to what type, and if you look into the label of what type of vascular events, arterial thrombosis, venous thromboembolism, and again, I think I would highlight that any patient being treated for CML needs to have careful monitoring for side effects, and at any point we have to weigh the risks and benefits of them continuing on therapy in the face of an adverse event, and try to be very careful about our decisions. I have clearly seen patients who have had vascular events on TKIs, and I've discontinued therapy, not ponatinib particularly, because of what seemed to be a clear temporal association and exclusion of other causes. But that's a very challenging area. It's sometimes almost impossible to understand what the role a drug may have had. Also, take into consideration that the benefit of therapy, for example, a patient with advanced forms of leukemia or a patient who has exhausted other therapies, we would not want to be cavalier to assume that any vascular disease that may be identified during therapy is drug-related, they must stop therapy. I gave the same argument when I was faced with the question about heart failure that was reversible and treatable with imantinib. I would not stop imantinib if I could treat heart failure if the patient needed imantinib to keep them alive and in remission with their CML. The details of the hepatotoxicity are also in the label, and you can see if you read through it actually that it says that fulminant hepatic failure did occur in 1 patient within a week of starting, and in 2 additional fatal cases. So there are 3 out of this fairly large phase 2 trial. But the second paragraph shows you the incidence of all grades transaminase elevations, which would be a harbinger of liver failure, and the incidence of grade 3-4 around 8%, which in my view is not really much different than imantinib or nilotinib, dasatinib. So monitoring is important for cardiovascular disease, for hepatic toxicity. Congestive heart failure was more limited. It falls into the same category. Unfortunately, we don't have yet an exact recommendation for patients who may start on a drug like ponatinib to have screening or pre-therapy assessment. We rely on our best judgment or the patient's best management to understand whether they do or they don't have vascular disease. We may come to a day where, for example, patients on nilotinib may have vascular studies or cholesterol or other studies done to make sure someone's paying attention to that. I would urge us all that we just need to be very good internal medicine physicians and healthy patients and advocates for good health overall, that CML patients generally live and do well. And we need to now pay much more attention to the general medical care and to make sure that we're, A, looking for toxicity or adverse events that may or may not be drug-related and managing cardiovascular risk as a particular problem. Hypertension is something where, now I need to delve in the most into what I would say is probably the gray zone of FDA interpretation of data and the label. And my understanding is that the FDA sees all the primary data, and a company seeking approval presents their case. The FDA has their ability to interpret the data. And what we see is a very high rate of hypertension, 67%. The thought is that the definition of hypertension here is fairly broad, meaning patients who have a systolic greater than 140 and a diastolic greater than 190. That would be stage 1 hypertension. That's the majority of patients. And this was at any point if they had a single reading in the clinic. And the pundits would say, if a patient walks into the doctor's office and has an elevated blood pressure at one point, is that hypertension? And I'll leave that up for discussion and argument. I think this is yet another example of our need to just monitor patients and understand the dynamics of their health as they're on CML treatment. And if you ask me, have you seen this phenomenon, I would say yes. I've seen patients in whom did not have elevated blood pressures who over time clearly drifted into some of the lower stage elevated blood pressures at stage 1 and stage 2 hypertension that was easily treated. Pancreatitis was probably the side effect of ponatinib that was expected to be the most highlighted, and doesn't occur frequently. It's clinical pancreatitis. The trend with TKIs is generally more lipase elevation and perhaps abdominal pain in the absence of radiographic or true clinical pancreatitis. But it clearly is an area that needs more work. Someone who's smart in the pancreas field basically has to figure out what button are we pushing with nilotinib and ponatinib in pancreas. And I'm always chagrined to note that in the randomized trial of imatinib and nilotinib, that 3% of imatinib-treated patients have high-grade lipase and amylase elevations. We just never knew that because we never tested patients. So this may be a phenomenon that may happen in all of our patients. So just a bit of summary now to close, and I'll leave some time for questions. It's up to us to know our tools, and this just is a bit of a simplistic slide looking at the different TKIs available, their dosing, the long-term safety, the time frame, and some of the things we have concerns about, the hematologic toxicity, and the non-hematologic toxicity. So to highlight the drug that we're speaking about today, we know that ponatinib can increase the lipase and cause pancreatitis. It can cause a rash probably with the most frequency. It does cause hypertension, and the black box warning clearly warrants attention, and we need to pay attention to the potential for arterial events and hepatic toxicity. So again, just a little bit more on chronic maintenance TKIs. If a patient is successfully treated on ponatinib, we have to pay attention like we would on other drugs. And we have some data on our other compounds, like imatinib. We were part of at least one study, which is called the Long-Term Effect Study, which asked, do we see other cancers, other health problems in patients treated for CML or Ph-positive cancer? And generally, no. The background rate is really what we observe. We know there are reports in the literature of some renal changes, bone disease, with reductions in phosphate levels. So there clearly are things to pay attention to, but no major risk of long-term exposure to imatinib. You know the cardiovascular toxicity of imatinib kind of came and went. Nilotinib and dasatinib, I mentioned that peripheral arterial disease has been reported. There are some studies which show no increase above the background risk, and compared to patients without CML, patients who had only imatinib, patients who had only interferon, so multiple different groups. But on the other hand, hyperglycemia is common. Vascular disease seems to be a theme, so I think more information is needed. And again, dasatinib, physicians have been warned, and it's now on the label that it can cause rarely a reversible form of pulmonary arterial hypertension. And I say reversible because much like a climber would have if they would descend too quickly, rather than, for example, fenfluramine, which was a supplement, a diet medication, which caused irreversible pulmonary arterial hypertension, which is quite dangerous. This is not what dasatinib can do, as far as we know. I was glad to be part of a recent publication where we looked at peripheral arterial disease in more depth. That original cohort analysis showed no difference, but we've just published in Leukemia that we may see, and you see the last sentence, that nilotinib was associated with higher rates of PAOD versus imatinib. so we are seeing some signal, and again, I would just include this in the panel of things we need to pay attention to, and take this into consideration for the risk-benefit ratio for nilotinib. So another important question is, where does ponatinib fit? Please don't reproduce this slide. This is a preview of my education session from ASCO. So for those of you that can't make it to Chicago, here it is. And this was the draft, and I was feeling rather strongly at the time when I wrote it, and then I edited it and added in the consider rather than switch. I'm a firm believer that early transcript reduction is very important. And if a patient has a slow transcript response, their likelihood of deep response is clearly diminished. And if we're very apt to put patients, so some of us or many of us are comfortable putting patients on dasatinib or nilotinib as frontline therapy, we should clearly consider switching them or switch them if they're already showing signs of slow response and lower odds of success. I say consider ponatinib only in the setting of a clinical trial. Would it be a frontline therapy option? But it could work all the way back to something you consider for a patient who had imatinib and in whom the other drugs were not a good fit, or you felt strongly about it and you felt that they needed that type of therapy to optimize their response. The second line is probably the one where ponatinib may fit a bit better. Patients had nilotinib or dasatinib and they have a poor or slow molecular response. The data is even more compelling there, that the likelihood of a molecular remission or a cytogenetic complete remission is quite lower. The fortunate is to say that there's many fewer patients in that group, but they still unfortunately exist. And so for them, I would consider a switch to ponatinib, or I'd also consider bosutinib, although bosutinib and dasatinib have a fairly similar spectrum of activity. So it would be a more limited group of bosutinib for that category. For patients who don't have a cytogenetic complete remission after a year on imatinib, again, if we're comfortable using the nilotinib dasatinib in the front line, we would clearly want to switch for that. Missed landmark, which is very important. I would say again that both bosutinib and ponatinib have data in the second and third line setting. Ponatinib really only in the second line setting after T315I, but that's why I would say I consider it in that setting. Molecular response that's incomplete by 18 months, you might consider a switch after management to nilotinib. Based on a trial, there was a switch trial for patients. So using evidence-based data, we would maybe put nilotinib ahead of the other TKIs that could have been studied, but I think any of the subsequent generation TKIs would be reasonable to optimize molecular response, and that's a bit more of a delicate decision. If the patient has had a second generation TKI and is a cytogenetic failure, I would definitely think about switching to ponatinib. Cytogenetic failure is a more grave concern than molecular slow response, especially at 12 months, so I think more strongly about ponatinib. I think I've tried to show you that the T315I is quite sensitive to ponatinib, so that's a natural. I would look at, in select mutations, there are select mutations that respond better to certain drugs and not so good to others. So the list of 299, 315, and 317 would respond better to nilotinib or bosutinib, but ponatinib would be clearly an option there. For patients who have P-loop or A-loop mutations, it's the 253, 255, 359. I would say that dasatinib and bosutinib, and to consider ponatinib, those are all good choices. And if a patient is transformed to blast phase, they need to be evaluated for transplant and after TKI stabilization. And it would be depending on the mutation and other data to make that decision. The good news is that the number of people that we need to make decisions for is clearly increasing, and this is now published. The projections, at least in the United States, for nearly a 250,000 patients living with CML. So we need to pay attention to these data. And I'd like to just stop there because I've gone a bit over, and I wanted to leave some time for questions. Thank you for your attention, and all of our advocacy groups. And also just quickly mention to look for me in New York rather than Portland as of August 1st, as I take a position in Memorial Sloan Kettering to direct the program there in CML and myeloproliferative disorders.
Great, thank you. Okay, so we will now, thank you very much. We will now begin the question and answers part of the webinar. Participants joining by webinar have the option of typing in questions through the chat function, or if you have a headset or a microphone, you can speak your questions that way. we're going to aim to take turns between questions here in the room and online inquiries. So, okay, let's see. Does anyone here want to start with a question? It's Cheryl Ann from the CML Society of Canada. I basically, and Greg and I have been having lots of discussions about this, and everybody around the world, I think, regarding some of the negative investor reports from yesterday regarding the toxicity of ponatinib, which you've addressed today in your presentation. But I wanted to see if you could talk a little bit more about your experience here at OHSU with your patients on ponatinib.
Well, I've had the privilege of being part of clinical trials, treating a number of patients, prescribing ponatinib. I think it's very important to look at the clinical trial data, of course, to be familiar with the label, but it's challenging for people who don't have that privilege to render opinions and to gather opinions about it. What we want to do as clinicians and advocates, rather than what we want to do as investment counselors, is probably a dramatically different agenda as well. So I think investment counselors and news about a therapeutic from an investment report has been driven by market share and applicability, and that's a moving target. How we use the drug, our comfort level increases as we understand and we resolve our questions about toxicity, and patients become more familiar with it. So I wouldn't dismiss them, but I would say the most important place to look would be peer-reviewed clinical journals, patient advocacy groups, because they house good information and access information, and clearly physicians and centers that have experience, rather than investor reports. The concerns are just really reiterating and highlighting and maybe taking out of context what are things that are in the label. And hopefully, if you can look at the label for what it is, which is a very inclusive for Iclusig document, in order to make sure a physician who is going to prescribe the drug knows any possible toxicity that can occur, and in the view of the FDA, that they understand any toxicity, whether it was attributable to the drug or not, just anything that can happen. And then if you contrast that with the patients, many of whom had no treatment options, who have done extremely well, who have had some toxicity. I've seen many of the toxicities I've talked about: pancreatic enzyme elevation, hypertension. I have not seen grave cases of vascular disease or any significant vascular disease. And speak to the patients who benefit, and this can be literally a miracle to have someone be put back into remission without alternative treatment options and appear like someone who easily went into remission with their first drug.
So you haven't had really unmanageable sort of severe adverse events at OHSU?
No. I wouldn't take just, that could be a bit of a bias. One center might be lucky, or maybe we take good care of a patient's care that they don't know. Well, I think we've all had I've had unmanageable adverse events on all TKIs, to be honest with you. But no, I haven't. My view is not that ponatinib is difficult to treat patients with, and that I've had unmanageable toxicities. I would say the things that I've seen, maybe it's a center bias, and we have 15 to 20 patients from clinical trials, and then additional patients post-approval. But I have not had the need to stop therapy due to toxicity indefinitely, permanently in patients. And patients who have had dose reductions or interruptions generally have had resolution and moved on and have stayed on therapy and continue to respond. So, kind of a follow-up question to that. Extrapolating, if this drug were accessible in other countries, other parts of the world, I heard what you were saying about managing the side effects, but what are the conditions where you wouldn't feel comfortable using it? For instance, if you didn't have certain infrastructure or couldn't measure certain things related to AEs. I mean, would you be any more cautious with ponatinib than with other TKIs? I think I view ponatinib as a drug that should be available globally. I don't see any of these toxicities as toxicities that can't be monitored or can't be managed anywhere in the world. You're talking about good clinical internal medicine and basic laboratory parameters, which should be able to avoid hepatic, pancreatic, hematologic toxicities, hypertension, cardiovascular disease. Those are not toxicities that can't be managed anywhere with good attention and detail and basic clinical instruments.
Okay, good. Okay, we have a question online from Jan Gessler, and it's actually up here. We'll go with it. He has a couple of questions. Is it expected that the treatment of emergent AEs, especially grade 3/4, also occur at a similar level in a fine-line setting? Are observations in EPIC similar?
So Jan, you're referring to the EPIC trial, which is the trial randomizing patients newly diagnosed with CML to imatinib versus ponatinib. That trial has just begun. There are patients enrolled at other centers, but we don't have any data yet. That is the most important question to answer from that trial. We're asking, what is the benefit of ponatinib potentially in the frontline setting, and what penalty might there be? So you can be rest assured that all of us will be thinking that the most critically about that, because it was thought quite critically of Longterm and dasatinib with regards to the penalty that those drugs offered, or what any savings for a newly diagnosed patient with regards to toxicity versus what benefit they gave. So well, that is the most important question. Not to dismiss the platform of the trial, but I think it's very likely that ponatinib will be more effective than imatinib. So the more important data to come out of that trial will be what are the differences in toxicity.
Yeah, we had a question. If you could just speak to dosing a little bit. You know, the recommendation of starting high and then decreasing, or how is it managed?
So I'm a purist when it comes to dosing. I mean, the dosing is uniform across all phases of the disease. The 45 milligram once a day dose. I apologize. I thought I had it in my slides. The ability of different dose strengths to inhibit the B3 kinase, and we saw that at 15 milligrams, B3 kinase, even resistant kinase forms, are inhibited fairly uniformly through the dosing period, although not entirely. At 30 milligrams, they are inhibited for the dosing period, and at 45 milligrams, they clearly are. So the dose was chosen based on that and based on the phase 1 toxicity, the maximum tolerated dose. I would start a patient on the standard dose. I wouldn't start low. But on the other hand, I wouldn't be shy to follow the label and to hold the drug or dose reduce, because I think, much like the other more potent TKIs, many patients, it's hard for us to judge exactly how much of a drug they might need. If it's different than the label dose, to still be effective to avoid toxicity. And I think ponatinib, for example, like dasatinib, might have a somewhat broader range. We might see trials where we say that the median deliverable dose is lower, in a newly diagnosed patient population, or with more follow-up of our studies. But right now, I started at standard dose, and I would be very methodical and follow the label, and reduce if you need to, and not to worry that, oh goodness, this is a resistant patient, and if they don't stay on 45, they're in trouble. I have many patients in remission on 15 and 30 milligrams, but only because they needed to be on that, not because I was worried and I lowered the dose because I wanted to back off or reduce the dose. I would never advocate dose reduction purely because of time and comfort with the response level. Whatever dose is needed to bring back remission is what you want to sustain, especially in a patient with resistance. Yep.
So you had mentioned pH-positive ALL. I assume that was with adult patients.
Yep. So the trial was for adults, and we did in the phase 1 and the phase 2 have patients with pH-positive ALL. They respond much like lymphoid and myeloid blast crisis, in that we were able to put patients into hematologic and some into cytogenetic remission. I think perhaps more exciting is that we've seen several trials with kinase inhibitors and chemotherapy, and we'll be waiting to see data with ponatinib in combination with other drugs active against PH-ALL, hypercVAD regimens, even simple therapies like vincristine and prednisone. None of these are in the label. None of these have been tested yet formally, so these are experimental. And but things to think about, and I think it might be a very good way to boost what response we can get out of chemotherapy in this subgroup. Also, in patients with more risk of treatment, we've seen very good data with using just a combination of steroids and kinase inhibitors. Dasatinib and steroids is probably considered a standard in many locations for an older patient or a higher risk patient with pH-positive ALL or lymphoid blast crisis. And I think that might be that might be a very good combination as well.
So clearly those studies would come first, but I mean, would you extrapolate again and kind of think of children? And I know that that's kind of a tricky situation, whether they don't often get prioritized for trials, but it seems like if you have a drug that's working so well, it would be great if it could get accelerated.
Absolutely. I mean, fortunately, adult-type CML isn't as common in children, but we know there are a number of children worldwide with what looks like adult classic Ph-positive leukemia. The children are always a special case because of, A, the implications of toxicity over time, development, and growth.
Right.
The penetration, for good reasons, of stem cell transplant for such leukemias. So they tend to be delayed, and I think it's purposeful to understand fully the adult toxicity profile, and to carefully, and then with a maximum tolerated dose and a dose range to then back calculate what is the applicable dose in children. And but I think we've seen consistently imatinib, nilotinib, a little bit less so dasatinib. I mean, they eventually find their way for children, and again, I think it's purposeful. But I'd be confident that ponatinib would potentially have a place in pediatrics, especially as an ability to bridge someone to transplant for short term. I think the risk-benefit ratio might be quite high there, and even for patients in whom transplant's not appropriate, maybe for longer use.
Right. Thank you. Okay, we have another question online. This one is from YC in Malaysia, and the question is, based on the published results earlier in your presentation, it would seem there is no advantage in using ponatinib for CML patients without the T315I mutation. Is this true? If so, does it mean that there will be no advantage in administering ponatinib in CML patients without the mutation?
I'm trying to read the question and understand that. I think the assumption based on the question is that that there's no advantage to the patients without. It's most useful for the patients with the T315I. Maybe to reiterate, I would say that if you took 100 patients with resistant disease and you're going to have a small fraction with the T315I mutation, they are probably going to respond statistically somewhat higher. But I would suggest that might be because you identified them as being highly resistant sooner than you did your other patients, and that's what we found in the trial. If you saw patients with other mutations, they respond next best. They respond quite well. And actually patients with no mutations, with probable other mechanisms of resistance that we haven't fully understood, statistically respond the lowest. So no, I would say that patients with or without the T315I are appropriate for this drug. The question to ask is where they are. And in this trial, you have to remember that the patients had failed nilotinib or dasatinib or both, or even in some cases 3 or 4 drugs.
Right.
So no, I'm not saying that there's no benefit for a patient without the T315I. In fact, there's a huge benefit in the setting of resistance to prior therapy. And there's an even greater benefit for the T315I patients, but it may not be because of that mutation. It's because probably they found themselves with a highly resistant mutation earlier in their disease course.
Yeah. I have a question. In one of the slides that was presented, you had a comment where there was a better response rate when it was used earlier and for younger patients. So would that give physicians a bias not to use it for older patients, given the safety profile?
I probably wouldn't want to look at it that way. I think we were looking at a population of T315I patients and saying they did better than average, and it might have been because they were younger. But patients in the trial had a pretty broad age range, and age wasn't a poor risk. It wasn't a negative prognostic factor, meaning it wasn't that older patients responded poorly. It was just that patients with a T315I mutation happened to be younger, and that may be really why they responded better. I think it tells us the opposite, that we may want to use the drug earlier and probably therefore using it in patients who are just chronologically younger because they're diagnosed with CML rather than later in their disease course. Does that make sense?
one of the previous questions, Greg Stevens, National CML Society, Dr. Mauro, one of the previous questions discussed how the thought process goes with ponatinib being considered maybe a bridge to transplant as opposed to an ongoing watch and wait treatment philosophy, and of course that varies from patient to patient. But we had a recent submission of a 35-year-old male that had been diagnosed 5 years or more, chronic phase, taking Gleevec, who had had a voluntary matched unrelated donor bone marrow transplant and has now shown positive for BCRA again. And we hear this happen from time to time with patients, but the question that the patient had, and one that we had worked with them to find information on, is would ponatinib in that type of case be considered maybe a bridge to a second transplant, or possibly just a continued watch and wait, or as your slide, where does ponatinib fit, would there be, since the patient is in chronic phase, just the opportunity to maybe cycle through the drugs that are available? And no mutations were reported in the patient.
So that raises the important question about, can a patient have a second transplant? There's a fair bit of risk and careful risk assessment that needs to be taken because of the prior exposure to chemotherapy, sometimes radiation, and what the implications immunologically are. The patient post-transplant is a special case. We published recently with a group from, or I published, I was honored to be just an advisor on a publication from a group in Korea who looked at discontinuation success after imatinib. And patients post-transplant seem to have a greater margin of success than patients who hadn't had transplant. Because we think we might bring back or re-empower graft versus leukemia effect. So the direct question is, can ponatinib be not just a bridge to a second transplant, but a maintenance therapy in a post-transplant setting? I would say certainly, because the risk of a second transplant may exceed the risk of waiting and treating with ponatinib. And as well, the other thing to note is, I clearly would not say that that patient can take it for a while and then stop. But someday we may see that even patients who have had resistant disease and drugs like ponatinib may be able to discontinue because they show what appears to be non-proliferative CML at some point. And I would be particularly encouraged or hopeful at post-transplant that may be equally as possible as in the non-transplant setting, or maybe more possible.
I wanted to come back to your comment about younger people were more likely to have the T215I mutation.
Yeah. Oh, is that the question?
Younger people are more likely. So why is that?
No, that's. If I did say that wasn't the intention. It's not that younger patients have the T215I. If you look at this study, the patients who had the T215I were just chronologically younger. I don't think that translates into that the opposite is true. I think just simply chronologically that if you look at patients through their disease course, if they're identified as a T215I, they're pulled out early at that point as being highly resistant, then they don't go on to other therapies, whereas other patients may have had exposure to a second or third or even a fourth TKI. So even that simple difference could change the median age. And that was the crux of the multivariate analysis. The typical patient with the T215I was someone younger, had less lines of therapy, had CML less numbers of years, and had the ability to take ponatinib and sustain higher doses of it.
Yeah, I have another question for Leon here. He's asking, is the label of the EU approval the same in Europe or are there differences?
I don't know the answer to that question.
Okay.
Perhaps because I'm a U.S. rather than an EU physician.
He also has one more question down here. He says, it is surprising that allo-SCT is only seen as an option in cases of transformation to APDC, where chances to survive allo-SCT is lowest. Is cycling all TKIs anyhow the preferred strategy over allo-SCT after the first and second line?
I think Jan's encouraging me to edit my education book even more. I think that's a fair statement that you can consider transplant at any point in CML. I included in that table at the point because the numbers of patients going to transplant in CML in the U.S. is so low, and the acknowledgement of the place of transplant is so different, that I wanted to highlight that if a patient has any advanced form of CML, it is, in my opinion, it is a requirement that transplant be discussed or considered rather than just a. Because if I was thinking I would have diluted the notion of transplant if I put it on there, because at any point, a patient or the clinical situation in certain parts of the world, transplant is much more feasible and practical. So even at presentation, transplant is still a treatment option, although it's generally not done. And I think treatment with a TKI is going to be useful in almost any patient prior to transplant. But in earnest, it's an option at any point. But I put it there because I think it's required in advanced patients because should they fail therapy and transform again, the chances of long-term success may be almost nil.
Well, kind of to follow up on that, I'm curious about the kind of dialogues you're having with your patients. I mean, as you add another TKI to the profile, are you having more conversations around mutations with your patients, or is it something that people aren't necessarily tracking? I mean, is it a certain percentage or a certain kind of profile of the expert patient? And kind of in that same regard, I think we had this experience of seeing like an emotional connection to a medication like Gleevec. People were on imatinib and Gleevec for so long, and that idea of shifting to a different drug, obviously these patients would probably have shifted at different times. But I'm curious about your conversations with the patient.
So the conversations are necessarily more broad. The newly diagnosed patient needs to and probably wants to hear about multiple TKIs. Updating a patient who's facing any question of resistance or intolerance now is a much longer discussion. I think it's challenging. It's more confusing for a patient because for someone on the other end, you're needing to give your opinions really on what and then highlighting things. You can't exhaustively go through everything, but the algorithm hasn't changed though. The goals of therapy haven't changed. The goals of success, which is long-term therapy, at least for the foreseeable future, that's well tolerated, that's putting that's an idealized response. So that hasn't changed at all. So there's no different conversation on mutations. We don't do it earlier, do it more often, change things. We use our best data, kind of our evidence-based data, and we kind of go from there. But the conversation is about, so what do we do with this status now? You've just been diagnosed with CML. What do we do? That used to be a very simple conversation.
Right.
There's old-fashioned therapy, and then there's this wonderful drug, imatinib. And I understand the emotional connection. Now there's a family of medications.
Right.
Someone has intolerance or resistance. It could be as broad as there are 4 different drugs I can talk to you about right now. And then it's up to us as providers and advocates and all of us to understand the details, because sometimes it isn't just a smorgasbord and you walk up with a plate and pick what you think you'd like or the doctor thinks they'd like. There are definitely a lot of data points that play into how to decide, and it's the clinical situation and what you know about the CML often can tell you at least something about which medication might be the best fit, and then clearly the patient, their comorbidities, their personality, their profile, and how they view the data. Many of my patients will hear the data, and to them, certain things are more concerning or more important to them. So it's a very individualized decision.
Thank you. And just to acknowledge that we have another 22 minutes technically in this webinar, and I think that there are a lot more questions, so I just want to keep maximize our time all the way till the 2 p.m. and keep taking questions.
So going back to the allogeneic stem cell transplant, to what extent are you aware that your colleagues, both domestically and internationally, are having that conversation with their patient population for the advanced stages?
I think transplant is viewed differently in different parts of the world. It's probably hard for U.S. physicians to understand because they may not, even within their own practices, they're not thinking about it. But or to see it as an alternative that may be more practical and even more accessible in some places. On the other hand, stem cell transplant and the care that's involved with it is costly and isn't an option for many people. which is where I really think oral delivered kinase inhibitor therapy is just such a blessing for patients in remote areas or where there isn't a good health infrastructure. So I think it's basically graded by the economy and the access to healthcare, which is different everywhere you are.
Even within the U.S.
Even within the U.S.
Yeah.
Exactly. A patient living in a remote part of the U.S., a bone marrow transplant means being displaced for a significant amount of time, and that simple fact may not mean it's not feasible. Whereas a patient in an urban setting next to a university center, that isn't an issue at all. So it can be that simple.
Do we need to go to an online question? We don't have any more online questions, so if there's any other questions in the room, we can go ahead and take those now.
There, just to share an experience that we've had lately, I know that everyone on the webinar today probably can envision their youngest patient as well as their oldest patient. And what we're seeing in the States, and we know culturally in other countries, our elders are revered, whereas sometimes in the States, you turn 40 years old and you're quote-unquote put out to pasture. We recently had a 90-year-old lady who has been living with CML since 2008, and her platelets had been historically high throughout treatment. She was initially treated with Gleevec and then went on Sprycel and did have some intolerance issues. And so the course that was taken with her care team was that, well, Miss So-and-so, you're 90 years old, you've lived a good life, but she had no comorbidities or any relevant, issues that could affect her. And so we were able to get her into the extended access program for ponatinib. And over the course of the past 5 months, this 90-year-old lady has gone from high platelets, lots of toxicity, to normalized numbers and almost undetectable at this point with no toxicities. So I think that's very encouraging. But Dr. Mauro, in your experience and talking with your peers, how are you seeing things break across the age range with response from patients taking ponatinib?
To be fair, there definitely is literature that, with age, tolerance of therapy can be different, and that's not surprising. It's also different tolerance of therapy depending on someone's psychological status, their comorbidity profile. So it's not just age, it's a number of factors that change the way a patient may respond or may be able to tolerate therapy. I have many patients very close in age to the person you're talking about who tolerate therapy beautifully, and I have patients half or a quarter of their age that can't take it at all. I'll be a little crude here, and I'll say that if the physician who takes the attitude that a patient, simply based on chronologic age, isn't suitable for therapy, I unfortunately wish them that they have a doctor like them. They get diagnosed with CML. Because if you're smart about it and you look at life tables and understand if you're 90, and if you're just 90, you have a very good likelihood of living a period of time beyond that. And if you're 90, you don't have any health problems, you may live quite a bit longer than that. So every patient deserves optimal therapy for CML, even if it turns out that you put them into complete molecular remission and they die peacefully with something else because the timer went off. That's fine. You handle every patient the same way. You look at their comorbidities and their disease state. You try to treat them the best you can, and then you adjust accordingly. Might you need to adjust in an elderly patient more often? Yes. There's good data to say that, but that's our job.
She's very fortunate. The last 2 weeks, she's been off gallivanting with her 88 and 86-year-old sisters. While her daughter stayed home and worried about them getting in trouble. So their life is beautiful at any age.
Speaking of that, and this will be probably one of the last questions, but when I saw the side effect around the severe bleeding, and it just brought up for me whether that is more of an issue for a woman in childbearing age, and how this drug how would you think about it differently for a man versus a woman? I mean, of course, I'm also ready to ask questions about pregnancy, and I know that that is something that doesn't get studied necessarily, but knowing that it doesn't get studied necessarily until later, if at all, it still just triggered for me whether it was more risky given that bleeding, and I don't know if that side effect is common for the other TKIs as well.
So the Santinib has an aspirin-like effect, and it's been published on that it has an inherent bleeding risk. Ponatinib has been studied, and there's a paper from the group at Hammersmith that it has similar properties. By just simply looking at platelet dysfunction and bleeding times, you can understand that the patient on a TKI may have a different bleeding risk. I actually looked at the opposite of, with imatinib. Putting someone into remission helps their general state of hemostasis, their ability to to clot and to have normal bleeding risk. But taking medications probably has somewhat negative risk depending on which medication. That being said, it's a small risk. It's probably somewhere in the range of taking aspirin.
Oh.
So generally, the bleeding risk we see in clinical trials is related to combination of thrombocytopenia and other other factors, plus that effect, or other medications. Not to blame. I wouldn't redirect it, but I would say thrombocytopenia plus aspirin is a bad combination. So thrombocytopenia plus Santinib or ponatinib or another TKI, if it had a similar risk that we don't know about, also might be more risky, but it's a small risk.
Okay. Thank you.
The other just comment would be patients are stable and on treatment and they undergo hemostatic stress. They can simply interrupt their drug for a period of time, and much like a patient is on aspirin or blood thinner would, and they can return to probably a more normal state and resume their therapy after the hemostatic stress is over. Like childbirth.
Let's see. Does anyone else here in the room have any other questions? I have one that came in from Pat, and I'm not sure if you exactly addressed this, but assuming ponatinib is available, why would you switch from imatinib to dasatinib or nilotinib? In that case, would you need mutation testing? Does that make sense?
So I think Pat, thank you, Pat, wherever you are.
The New York airport.
If you think about it quite simply, if you had a drug that was maybe better at treating resistance, that would be more likely to prevent other types of resistance, that would work maybe the same or statistically better. If you look at the data after imatinib using nilotinib and the data after imatinib using dasatinib, the data with ponatinib for patients who had imatinib, nilotinib, dasatinib, or a combination, or maybe two for is about the same. Sometimes, in some cases, better. So third line, fourth line therapy is better than second line therapy. That makes you say, well, maybe I ought to swap out my second line therapy.
Right.
But it's, again, it all boils down to an individualized decision about risk benefit. Oh no, I was going to say I foresee that algorithm where the patient has had imatinib, they don't have a T315I mutation,
Right.
and should they be considered for ponatinib? I would say absolutely yes. In addition to all the other therapies.
Yeah. So just a quick question for me. Based on the, when we look at the adverse events that could happen or the side effects that could happen, are they kind of late-breaking? Let's say if a patient is really done great on the drug, and a year out has had a good response, tolerated very well, are we going to see things that can happen just spontaneously without warning that, would be related to the drug?
There's a pretty consistent pattern that started with imatinib where biochemical toxicities are generally early. Immunologic toxicity is definitely early.
Yeah.
Because it's a disease-related phenomenon more than a drug effect. Slower effects on that maybe concerns about vascular disease or other things, those might be later side effects. A good example of a compound-associated toxicity, pleural effusion.
Right.
With the dasatinib. They can happen early. They can happen within the first year at a decreasing rate, but it's not a blunt decrease at a certain point. They can happen late as well. Some patients have been diagnosed with them at 2, 3, or 4 years or beyond. Pulmonary arterial hypertension, rare. It's often diagnosed late after several years of dasatinib exposure. So that might have that may be a gradual building drug toxicity. So we definitely have to watch for those. But the simple biochemical and hematologic toxicities, I would be surprised if we would have some sort of epiphany of new toxicities at 12 to 18 or 24 months. That would be inconsistent with everything we've learned about TKIs over the last decade. But the other things, the maybe intrinsic compound-related toxicities like vascular changes, including some of the ones we already know about, like PAH and PAOD, we have to watch them over a much longer period of time.
And just as a follow-up to that, I mean, I know for my case and as well as Greg, we've talked about this a lot. We have a lot of questions from patients who all of a sudden are talking about and complaining about what they quote as side effects with their drug treatment. And when we question them along further, we find out there's been major lifestyle changes. When your experience with ponatinib, can you say, and this might, I don't want to put you on the spot at all, but patients that you have in the trial, you kind of can see which patients have more of a healthier, robust lifestyle versus those who don't. Would you say, being energetic, exercising, moving, trying to maintain a good, healthy lifestyle would kind of help you in the long run with those potential problems with ponatinib?
Well, there's no way I could say, of course, that's going to help people's general well-being. I think we've seen sort of validated tools used in clinical trials, and once people get past early toxicities, irrespective of their activity or their profile, they generally tend to feel better. So if you combine, boy, I have CML and I really ought to do everything I can to feel better, plus I go into remission, and that's probably a synergistic effect. If you took someone who was diagnosed with CML and they went into remission, but they said, well, this might get me soon, I'm just going to eat cheeseburgers 3 meals a day and sit on the couch. They're going to negate any benefit of having their CML go into remission. They might feel worse at the end. And someone might be somewhere in between. So I think, yeah, definitely lifestyle and general health and outlook is important. I think it's allowed to buoy people through toxicity probably a little bit better. It's all important. Mental health and helping people cope too. I think we tend to under discuss the impact CML can have. My nurse Linda, who happens to be in the room, and she'll know what I'm talking about. I mean, sometimes patients after a few weeks or months will share with you how deep an impact it might have had, even though they had very straightforward chronic CML and went on a clinical study and did very well with a novel new drug and are getting great news. But yet, even at that point, it might hit them like a ton of bricks that I really do have leukemia, because they might have been in a bit of denial for the first few months. So we have to pay attention to that.
I've had a couple of situations where ponatinib was recommended for the patient for their CML, but once that person saw the black box warning, they were too afraid to take it. And they didn't have any particular cardiac risk other than being American and maybe in their 50s or 60s, and they smoked 20 years ago, but they quit, or maybe their cholesterol was a little high. Is there a particular workup or anything you'd recommend, maybe to give some peace of mind that they wouldn't be the ones with the stroke and the cardiovascular event?
Karen, I think there's a natural tendency for people to drift away from rigorous internal medicine when they get diagnosed with cancer. They've often drifted away from regular screening. So I just prescribe for people to sort of get back on the wagon and say, but I also recommend a baseline or an interim. Even if they had a negative stress test 3 years ago and they were on imatinib and now maybe they're looking to need ponatinib or something like that, I would say if there's concern to that degree, I think that's probably one of the best ways to cope with it, is to say that there's probably no medical reason not to do that. Let's do that now, and let's reassure you, much like you'd reassure someone who had a heart attack that yes, you can go out and exercise. That no, you don't have any vascular disease now. We're going to keep a close eye on it, and engage another specialist. For example, in Germany, where some of the best data on the Longterm and peripheral arterial disease has come out, they're adapting. What I would say is what a great philosophy is just to say, well, we just need to be good internists, and we need to make sure we look if someone had a glucose and a cholesterol and triglycerides, and if they're not on a statin and they need to be, let's put them on one. Because just because they have CML and someone's not paying attention to their lipid profile, we might actually make a huge benefit. And so I think baseline screening, adding therapy where needed, lowering risk, and then careful monitoring should probably be a terrific, way to reverse what could be a very, not surprising and very, I'm not surprised at all the patient would see that and be like, goodness, this is, this sounds like it's going to, as much as it could help me, it could really hurt me. And say, well, let's figure out what your risk is, and let's do what we can to lower that, and then let's follow you. And that should, and then of course to put on the scale the threat of resistant CML, even if the vascular risk was higher, I think in certain situations one has to remember what we're dealing with here, which is a potentially fatal blood cancer versus a possibility of vascular disease.
Okay, I am mindful of the time. I want to wrap up the meeting. I really want to thank you, Dr. Mauro, for all of this information. To me, actually this conversation, beyond just the information that you provided, is a reminder of why the advocates and the physicians need to work together in dialogue and keep this discussion going, so that I will say that we see you as a resource in the community, and we look forward to continuing the discussion and sending questions your way, because this is probably the beginning of the questions that will come from our community. And I also want to thank everyone, all of the advocates around the world who joined the call. And of course, this session is really dedicated to the patients around the world, and hoping that everyone can be able to access drugs like ponatinib and other drugs no matter where you live. So thank you, everybody, so much.